So symptoms for metastatic prostate cancer can vary depending on where you develop metastases, basically. So I would argue that most patients will present with bone metastasis, which is the most common site of disease, followed by nodal involvement, and then soft tissue and visceral disease. So if I have a patient with bone metastasis, one of the most common symptoms that occurs is actually bone pain. And so, so all the patients, we should think of bone pain, fatigue, when we are suspicious of metastasis. But if, for example, if you develop metastasis in other sites, such as nodal involvement or pelvic region, for instance, you can develop other types of symptoms, such as lower obstructive symptoms, edema, etc. So I would argue that the presenting symptoms depends on where you have metastatic disease, but bone pain is one of the most common symptoms. So bone metastasis is the most common site of metastasis in patients with metastatic prostate cancer. They can occur alone, meaning a patient might present with bone-only disease, which I would argue might be half or even more than half of the patients we see in clinic, or patients can present with bone metastasis plus other sites of disease, and that can go up as 90% or so. And then you can also have patients who present with nodal involvement only, or nodes plus visceral disease with no bone mets. But that group of patients is probably a minority. The biology of prostate cancer is extremely important and does have prognostic and therapeutic implications. Patients with bone mainly or bone predominantly disease are different than patients with visceral disease, for example. And I'm thinking of patients who have straightforward adenocarcinoma of the prostate without neuroendocrine features, compared with patients who develop visceral disease that usually had poorly differentiated clones of the tumor where neuroendocrine features can arise. Again, it does have to know the characteristics of the tumor and the biology of the tumor does have predictive prognostic implications. So it's important for us, for treating physicians to know what type of prostate cancer does this patient have. So historically, we have been using conventional scans, including bone scan and CAT scans, to diagnose men with metastatic prostate cancer. In trials, we have been still including those conventional scanning as part of the protocols, but I would argue that novel imaging using PET scans with prostate-specific tracers are being increasingly used. We now have a number of ones who are either FDA approved or soon to be FDA approved, and I'm thinking about PSMA, Axmem, or flucyclovine, choline, fluoride PET. So the advantage of these PET scans or the use of these tracers is that they increase our ability to diagnose metastatic disease much sooner compared with the use of CAT and bone scans. So in the future, as we tend to use more and more PET scans for prostate cancer, we'll very likely be diagnose prostate cancer or at advanced stages much earlier. PSA has been historically a biomarker that we all use. There are some conflicting data about the absolute number and the value of that number, but it's true that we all use it to monitor response to treatments, right? So we usually say that symptoms are relevant, and then scans are relevant, and then numbers, meaning PSA, is relevant too. What happens is, as we expose different treatments for patients who develop, progressive metastatic CRPC, you are basically selecting poorly differentiated or undifferentiated clones of this prostate cancer. So in other words, you are selecting clones that are less likely to respond to androgen-directed therapies and might be, and their growth is being driven by other mechanisms and pathways. And so when that happens, PSA is less important. So in other words, in clinical practice, it is very possible that we see a patient who is progressing despite low levels of PSA or even no PSA at all. when we have a patient with bone metastasis and we know we have adenocarcinoma of the prostate, regardless of the Gleason score, we can consider all treatments available for this patient, including androgen receptor target therapies, chemotherapy, bone target therapies such as radium-223, or even dendritic cell vaccine Prevenge. When we have patients with soft tissue or visceral disease, we usually consider chemotherapy becomes a stronger option, although we do have data showing that androgen receptor target therapies are options as well, such as enzalutamide or abiraterone. But other therapies, such as radium-223, become less valuable because they don't work for patients who have disease outside the bone.